something that was actually torn out at this conference. We first presented NEBSA as a hosted it 2 years ago. And the whole idea came from essentially very busy on quarter weeks. We have many of these, and I think everyone is really seeing more and more bariatric emergencies. But we're not really capturing this data. And certainly for us, it has a lot of implications for our service delivery, our on calls, and we don't know where the patients are coming from. We get phone calls from all around the country. Patients come from the UK, the NHS, the private sector, and from abroad. And it's very difficult to actually plan your service, plan your on calls. And it's a very mixed bag of patients. It's very difficult to predict their care needs. They have a lot of intensive care needs, understanding their nutrition demands as well. It's also become very topical. There's a lot in the press about this now with health tourism, and a lot of public interest in bariatric emergencies. And the difficulty comes in how we actually quantify the burden of bariatric emergencies to the model NHS. We looked at our own data to start off with at LIBSS, and we modelled this back in 2018 and predicted that our numbers are just going to go up and so now in 2024, we've exceeded this. I'm sure many of you are in a similar situation with hospitals. There's not much in the literature. Our friends at St George's have published their single centre experience, but unfortunately we use the NBSR, and that's great when we can capture our complications, but certainly a good plug for version 3 of the NBSR, which I'll be sharing. But if you've got any comments or any suggestions for the next version, then do get in touch with me, talk to me in the coffee break. But at the moment, if patients if they haven't had their index operation and it's not officially in the NBSR, we're not really capturing the complications. And so what we needed is something a bit more granular, something that we can use as a research tool, and a way that we can actually analyse our emergencies that come through the door. So the aim of NEBSA, the National Emergency Bariatric Surgery Audit, is to capture this, to call the current trends in managing bariatric emergencies in a cost-effective manner. So we use a fairly simple data capture method using Power Apps. It's a fairly straightforward way of recording data. It's a lot of it's multiple choice entry, and it shouldn't be too exhaustive to enter having done your horrendous bariatric emergency before. And Mohamed worked extremely hard to get the census on board and help ensure that everything is GDPR and NHS level compliant. So if you're not part of this, then please do join. Our collaborators are fantastic and done any of this without you, so we're really grateful to everyone who has some data. There's lots more data coming through, and there'll be even more to present in the future, and so Mohamed can help guide you through the process. So having designed all this and piloted it towards the end of last year, we've been collecting data since December. Different centres have come on board at different points in their 6 months data collection, and we're pleased to now report some of our findings. So now I'm going to hand over to Mohamed to take you through the exciting findings.
Thank you very much, and thank you to the committee for hosting us again one more time. The inclusion criteria are very simple. They turn up to your hospital, they've had an intervention to diagnose or treat complication following bariatric surgery. They're included. They turn up, you assess them, they're okay, that's it. There's nothing to worry about. We've registered a large number of bariatric centres across the UK, and there's the hospital in red is where I work. It's PGH, is not a bariatric centre. But this also signals we're including district general hospitals who are not bariatric centres and also look after these patients to come forward and help us gather more data. this work would not have been possible without every single person on that screen. We are indebted to our collaborators, and there's also collaborative authorship included in all of our papers if you have participated in submitting patient. This is a list of centres who've approached and are still working towards getting on board with NEBSA. I highlight Homerton's under energetic management right now, so this is a call here to the centre, second time in a row and second year in a row. Please join NEBSA. Right, now to the good stuff. The bars in red are still data to be analysed. We had 149 patient details submitted. Out of those, 119 were eligible and are being presented for you today. Special mentions go to Chelsea and Westminster, who have 20 patients who still not yet to analyse. Salford have 35, Central Chichester still have 77. So, thank you very much. We're looking at 200 patients almost of data in a 6-month period of research data collection. Patient characteristics, predominantly female patients, predominantly 40 years old, length of stay, median time is about 3 days, and most people, it's a 3-way split, presenting within a month from an operation, then the first 2 years of the operation, or further on down the line. Predominantly Caucasian patients, with ethnic minority patients forming 13% of our patient population in NEBSA. That also equals 13% of ethnic minority patients across the UK. We looked at where the patients had their index operation for bariatric surgery, and we also looked at their engagement with NHS weight management services. And it's 50-50 with that, so half the patients who had surgery or were on the pathway to have surgery within the NHS, the other half were never on the pathway. And again, it's a 3-way split. For reporting hospitals, a third of the patients turning up had surgery at their index hospital where they were admitted for an emergency. A third had surgery elsewhere in the UK, where there was a private centre or another NHS hospital, and a third were from abroad. Roux-en-Y, gastric bypass and sleeve were the commonest operations, which again is in keeping with practice across the world essentially. Gastric balloons and gastric bands come next, and OAGB also feature about 10% each. And then there's the old division here down on one session. So before we go ahead, the lead time, numbers are still too sparse to kind of give us an indication if this is bimodal or not. But Roux-en-Y basically turn up 6 months down the line, sleeves turn up within the first month. Gastric balloons turn up within the first few weeks, and then numbers become smaller than that. Also gastric bands turn up many years later. This is the aggregate length of stay for an emergency, categorized by the type of surgery that they have. We're looking at almost 700 days after a bypass, almost 600 days after a sleeve. And then total eventually is about 2,000 days from bariatric complications across the UK in 10 centres. We looked at breakdown of commonest diagnosis following each operation. Roux-en-Y predominantly was bowel obstruction or internal hernias. Sleeves were predominantly as predicted leaks or intolerance to a twist or stricture. Despite a small number, OAGB were predominantly due to leaks or malnutrition. And then balloons, as predicted, were intolerance due to the balloon basically giving you gastric outlet obstruction and the typical band sleeve. With the re-interventions, bypasses had to have laparotomies or adhesiolysis or washouts. Sleeves had to have stents or OGDs to diagnose any problems, as well as treating the leaks. We had 4 revisions on the table across the UK in 6 months, as well as laparotomies. And then again, complications with OGB were significant despite the small number of cases reported. Laparotomy rates, about 10% of patients had to have a laparotomy. About 20% of patients had to go through IT or HCU, and And sadly, there were 2 mortalities reported, which we break down in the following slide. One was after gastric perforation, after a gastric balloon, and I actually had to have a partial subtotal gastrectomy. And the other one was a leak from a feeding dredge tube that sadly passed away due to multiple organ failure. This is a very significant slide. It shows the burden essentially, and if you want, cost following bariatric complications. And also, it also further highlights the amount of bed days that cost these patients and the trusts who are treating them. And we're looking at an aggregate of all these days, about 1,000 days of nutritional support. And if you say, for example, TPN, about 200 days of TPN, how much TPN costs? £200, £500, plus the inpatient stay, that's nearly £1 million, 0.75 in fact. The limitations to this is that we had to stagger the starting day for different trusts because we didn't want to wait any longer and lose the momentum and the support that we have from our teams. This is mainly trainee-led, so people move on after 6 months or a year. So we had to have offering different starting points for different centres. Half of the centres that you see are still in the data capture phase. It's a wildly varied approach to QI. Some centres had to have ethical approval for this, even though it's an audit and a prospective pseudo-anonymized approach. Sometimes some centres joined just by email. Most people wanted me to take them through the database and show them the 2-factor authentication process to be happy. So we've had 20 Teams meetings to get this off the ground so far. This is all done through people's free time, the IT department at Newton, as well as mine, as well as the academic committee, steering committee for NEBSA. And this does not come without its technical issues. And because of the small number of patients submitted, even though it's 120, it's still difficult to determine causality, but it's certainly a starting point for us to take things further. The vision here is this becomes the bariatric version of NEBSA and becomes a open free source arm for bonds and BSR, as we discussed in other meetings as well. There's lots of challenges. This is unfunded, this is everyone's free time. We are struggling with finding free software the NHS can provide, and we also lack a dedicated research team. Lots of work to do, so we've prepped a manuscript for the proposal as well as the first iteration of the report. We want to do an economical analysis of how much this is actually costing the NHS. I was making calculations in my mind this morning. The NHS pays about £50 million to fund elective bariatric surgery. We've got enough money here, about £1 to £2 million of complications worth. This is a perpetual audit. I've submitted a proposal for this to HQIP, and we're going to link up with them further on. We need to submit ethics to be able to collect postcodes and NHS numbers and further get more granular and meaningful data. Last time we presented this at BOMS, lots of dietitians were excited about it, lots of psychiatrists were excited about it, so we're widening access to other allied healthcare professionals and other non-surgeons in the bariatric MDT to come forward and help us submit data. We give authorship, so one of the nurses at Chelsea and Westminster is actually as part of the collaborative authors. She actually went and identified 20 patients where they were being submitted to the database. We're trying to look for more centres to join. Second call, Hamilton. Again, not going to say it. Not going to stop saying it. And we want to widen collaboration with the Royal College, with Dietetics Society, TPN Society, everyone really who looks after these patients. So we want to offer a detailed trend of how bariatric complications are being managed in the UK. We want to widen the knowledge and further influence policy and workforce planning. And actually, all of these are being paid by your trusts. If like everyone else, presumably is being paid on a block contract for complications. So what you're being paid for a lap appendix is what you're being paid for 6 months of TPN. And we want to widen the knowledge in the surgical curriculum and link up with JCST to look at this as well.